Omar, I want to kick it over to you. So do you have access to the Flex device, like being in the OBL setting?
I have access, and I use quite a few of them on the early market release for the company to test them out, and definitely did like the ease of use of it. But just because we're in OBL, we're in Memphis, I got to remember what MAC I'm in. It used to be Cahaba. It causes for some challenges, right? Because like a lot of devices, when they first hit the market, they're usually targeted. The codes, the reimbursement codes go for hospital, right? HOPD or hospital-based labs. And that's the right way. I mean, you have to work the process. So the OBLs, unfortunately, are kind of the last to see these great advancements, right? The downside to that for the OBLs is like the majority of the patient population is being treated in OBLs, right? That benefit from these wonderful inventions and devices, especially with the Flex device. And unfortunately, just because of pricing, and they have to have a certain price point. This isn't the company trying to be greedy. Like, no, it is a reason that they have to set that for reimbursement. CMS looks at this, and reimbursement's going to be based on the cost intensive of the device, the work it takes to do it. So we understand that. So I haven't been able to use it as much as I would love to, just because I have to be here to take care of my patients. And if we're unable to, if we're spending more money on doing the procedure than we're getting reimbursed, it doesn't, we can't be here for our patients.
Of course. So let me ask you this though: you've had your hands on the device, Omar, and Ari's told us like some like the ways that he uses it. Yeah. Do you use it any different? Is it any differences in how you use it, number of passes, or?
No, not really. I mean, I think Ari and I mean, he's dedicated to vascular access, such as myself, and when you've done the number of cases that we've both done, we all find different ways. But yeah, the key is with this device, it's as he's explained, it's 3 blades, right? Kind of, if I can get my 3 fingers right. And it's creating a constant radial outward force, right, of 1 atmosphere. So as you drag it through something this large, if it gets big, it's just going to come out, and it's going to keep in nice apposition or contact with the wall. And it's creating micro incisions. You're essentially weakening the intimal hyperplasia, right? You're weakening it so that when you pull a balloon out, it's going to break up easier, right? With less atmosphere. So yeah, the whole point is the more times you take it through, spin it, the more surface area I can get without overkill.
Sure. I get that.
Same as him. Yeah.
So any ways, question for both of you guys, but we'll start with Omar. Any ways where the device is kind of a hindrance, or not a hindrance, but maybe some obstacles you've had to overcome, like, hey, it's best not to unsheath in this position, or, oh, sometimes when I try and resheath and I'm next to a lesion, it gets hung up or it gets stuck in the sheath. I don't know, just anything like that. Like, because there are going to be users out there who are going to have this for the first time, and, just anything that you've learned along the way that may help somebody in those growing pains with new devices.
I think to me, the learning curve was quick, but it's more so just, and it happens quick, is getting used to moving it forward, unsheathing, pulling it back, and then resheathing to go back forward, right? And like when I say this, it's just, there's just several, like, you go do this first, or which one comes first. But as far as devices are concerned, to me, what's so amazing about this product is that it is so easy to use, and I don't see why I can't really find a situation unless it is a very, very tortuous fistula, which in those cases we have trouble with lots of devices. And because it's over an 018 wire, 018 wires don't do well with severe tortuosity. You can't get enough pressure on them. So if something's severely tortuous, it's going to be hard to get that device through. Now, having said that, and Ari can agree or disagree with this, most super tortuous accesses are very large, and they're going to be bigger than the device is able to handle. But no, I haven't used it near as much as Ari, but when I did use it, it moves. It's pretty. It moves good. I didn't find anywhere where I couldn't use it in the situations that caught me up.
Yep. Ari, same question. Any growing pains?
No, I think Omar did it right when he was patting his head and touching his stomach at the same time.
That's right.
Thank you for the description for our audio only
right,
listeners.
about, hey, do you pull the trigger or hit the button? No, I think what your point is well taken, Omar, about the 018 and the tracking of a device across that. So in acute angulation, I think it can become a little bit challenging. I've had cases where, for example, if I were in the percutaneous world where we have a reverse perforator, so you actually get a Z, right? So you get a wire across, and it is enough to straighten that perforator out. But when you take the flex in that particular instance, when those blades are open, you're really not at 1 atmosphere. You're at that compression of the wire pressure closing down over the device. And so that's where you have a risk of getting a dissection. That's ultimately been it. I think that, for restenotic lesions, which is, the moneymaker for this, in most AV access, certainly the bell curve lesions that you see within the circuit from the arterial inflow, wherever that may be, to the outflow, this device works beautifully. I would say that the more developed that access is, the more passes are often required to get the desired result. So typically in a well-established access that is very well arterialized, we'll do 4 passes without a hesitation. If you're in a new AV access and you're looking for, hey, I've got this stenotic lesion, we're early in the cannulation cycle and that lesion is quite tight, I'm a little bit more judicious and we'll do 1 pass and then shoot a little bit of contrast to see if we have any luminal gain, 2 passes, etc. And then just a little bit to be sure that we have it under luminal gain, or evaluate it with ultrasound to make sure that you don't have any extravasation or blush outside or hematoma outside the vessel. Short of that, no, I'm guns ablazes with use of this access. I'll use it in declots. You can use it in grafts, use it in stent stenosis. I mean, that's the thing about the power of this device, is that it was designed and they've studied it in real world populations. They're looking at all comers. They were not specific. And, it's sort of a gutsy thing to do for a device company, is to say, hey, we've got a problem that we're trying to solve, and we want you to really put it through its paces. We want you to put us in a situation to make it fail. And, and I think that's what's really extremely admirable about how they've done this. And it's really quite nice about what they've done, because really all we've seen is a reduction in the radial tension when we do the balloon and angioplasty, and a reduction in your typical elastic recoil, because you've treated those collagen microfibrils, we've broken those down, that intimal hyperplasia, and it's been incredible. So from that regard, hats off to the company, and nothing specific about caveats other than very tight acute turns, like any device, like a stent or anything that's on a trigger mechanism. It's tough to get the mechanism in and out also.
Yeah, fussy.